All right. Welcome back to NeuroClarity, the podcast that demystifies clinical neurology one high question at a time. I am Honorary Victor, your host, and today's episode is all about stroke prevention, localization, and the subtle anatomy that can trip even the sharpest mind. Whether you're preparing for the boards or just brushing up your skills, this is the right dose of neuro that you've been waiting for. Let us dive into four fascinating cases that test your clinical reasoning and anatomical precision. Stay sharp, you will get a recap at the end. Let's begin. Let's start with prevention. Here's the case. Which of the following patients should be managed with antiplatelet agent for stroke prevention? A 50-year-old man who suffered an ST elevation myocardial infarction last week and has an ejection fraction of 30% with anterior wall akinesis and left ventricular thrombus. B. A 49-year-old woman with a mechanical heart valve. C. A 52-year-old man with hyperthyroidism and intracranial atherosclerotic stenosis. D. A 76-year-old man with atrial fibrillation, diabetes, hypertension, and congestive heart failure. And E, a 70-year-old man with intracardiac thrombus. What do we think? Right off the bat, the answer is C, a 52-year-old man with hyperthyroidism and intracranial atherosclerotic stenosis. But why is that? Now, this patient has intracranial atherosclerotic disease, which is a known non cardioembolic source of stroke. Evidence from the WASID, which stands for Warfarin Aspirin Symptomatic Intracranial Disease Trial, showed no benefits and actually showed more harm when you use warfarin compared to aspirin. So, therefore, for non cardioembolic stroke, antiplatelet agents like aspirin are the go to medications. Now, for other options like mechanical valves, AFib with high CHA₂DS₂-VASc score, or intracardiac thrombus, those would require anticoagulation and not antiplatelets. Let's take a step back a little. What do we know about the CHA₂DS₂-VASc score? The CHA₂DS₂-VASc score is actually used to estimate the risk of stroke in non-valvular atrial fibrillation, and it helps us to know whether or not we are going to give anticoagulation therapy. It's a very crucial tool and it is used in assessing stroke risks in patients with atrial fibrillation. Now, each letter of the CHA₂DS₂-VASc actually represents a clinical risk factor and points are assigned as follows. First, congestive heart failure is given a score of 1. Hypertension is given a score of 1. Age greater than 75 years is given a score of 2. Diabetes mellitus is given a score of 1. A previous stroke, a TIA, or a thromboembolism is given a score of 2. Vascular diseases like MI, peripheral arterial disease, or aortic plaque are given a score of 1. Age between 65 to 74 is given a score of 1. And sex category, in particular female sex, is given a score of 1. You have a maximum point of 9. How do we interpret it? Interpretation is actually based on the age of the patient, and the stroke risks are classified into low risk, moderate risk, and high risk. A score of 0 in males and 1 in females signifies a low risk, and for those patients, no anticoagulation is required. A score of 1 in males and 2 in females indicates moderate stroke risk, and you should consider anticoagulation based on the bleeding risk. A score of more than 2 in males and more than 3 in females represents a high stroke risk, and oral anticoagulation are recommended, including DOACs or warfarin. The key points to note from the CHA₂DS₂-VASc scoring system are: 1. Age and stroke history weighs more heavily, with each having a point of 2. Female sex alone does not warranty anticoagulation unless other risk factors are present. The preferred anticoagulants are the direct oral anticoagulants, which includes apixaban or rivaroxaban, and they are even preferred over warfarin in most patients except contraindicated. This score helps us to prevent undertreatment of atrial fibrillation patients who may not have obvious symptoms. So, back to what we're saying. Clinical clarity tip. Remember, use antiplatelets for arterial thrombotic strokes and anticoagulants for cardioembolic causes. Next question. Here's a classic localization case. A 49-year-old right-handed man with a history of atrial fibrillation and hypertension presents with acute onset of right hemiplegia affecting the face, arm, and leg. His gaze is deviated towards the left and he seems to have right homonymous hemianopsia. He is globally aphasic. What is the location of vascular occlusion? A. Trunk of the left MCA before the bifurcation. B. Lenticulostriate branches of the left MCA. C. Inferior division of the left MCA. D. Penetrating branches at the level of the pons. And E. Superior division of the left MCA. What do we think? Well, the answer is the trunk of the left MCA right before the bifurcation. Now, this one is rich and you've got to know this. We have hemiplegia, which points towards internal capsule involvement via the lenticulostriate arteries. We have aphasia, which points towards dominant hemisphere cortex involvement, meaning the Broca's and Wernicke's area are affected, causing global aphasia. We also have gaze deviation, and this is due to damage to the frontal eye field. The right frontal eye field pushes the eyes to the left. Remember, the gaze will be towards the lesion in cases of stroke. Next, we have homonymous hemianopia, and this is due to the fact that the optic radiations in the MCA territory is affected. All this points towards a proximal MCA occlusion affecting both the superior, inferior, superficial, and deep territories. Neurology nugget. Remember, global aphasia plus full hemiplegia plus gaze deviation, think MCA stem infarct. Next question. This is a quick anatomy challenge. Which of the following is incorrect regarding the intracranial circulation? A. The anterior cerebral artery and the middle cerebral artery arises from the internal carotid artery. B. The posterior cerebral arteries are branches of the basilar artery. C. The pericallosal artery arises from the anterior circulation. D. Lenticulostriate branches arises from the posterior cerebral artery. And E. The recurrent artery of Hübner arises from the anterior cerebral artery. Well, this is a quick one. This is actually a very easy one. And if you've watched our episode on cows, which is the circle of Willis, you will be able to spot this right away. So, if you've not watched our episode, look at the link above. You can click it and it will take you directly to that episode. That being said, our answer is lenticulostriate branches arising from the posterior cerebral artery, the PCA, which is option D. The lenticulostriate arteries actually come off the middle cerebral artery and not the PCA. They penetrate to supply the basal ganglia and the internal capsule, which are critical real estates in motor pathways. Here's a 10-second refresher. The ACA and MCA, that is, the anterior cerebral artery and the middle cerebral artery, originates from the internal carotid artery. The PCA, which is the posterior cerebral artery, arises from the basilar artery. The recurrent artery of Hübner arises from the anterior cerebral artery. And the pericallosal artery is a continuation of the anterior cerebral artery. Next question. This is our final case. Prevention again but with lipids in the spotlight. A 50-year-old woman with controlled hypertension presents to the clinic with a history of TIA, that is transient ischemic attack, about a month ago. Aspirin 81 mg was started at that time. Cardioembolic workup was negative. Carotid ultrasound scan demonstrated non-significant stenosis, and low density lipoprotein, that is LDL, was 140 mg per dl. Which of the following agents has been shown to prevent recurrent cerebrovascular events and should be used in this patient? A. HMG-CoA reductase inhibitors, that is statins. B. Warfarin. C. TPA, that is tissue plasminogen activator. D. Heparin. And E. Hormone replacement therapy. What do you think? Our answer is high intensity statin therapy, which is your HMG-CoA reductase inhibitors. There is something we call the SPARCL trial. SPARCL stands for Stroke Prevention by Aggressive Reduction in Cholesterol Level. It showed that atorvastatin of 80 mg significantly reduces stroke reoccurrence in patients with prior TIA or stroke and LDLs between 100 to 190 mg per dl. Warfarin, heparin, and TPA aren't appropriate in this setting. And hormone replacement therapy, well, they are actually associated with a higher risk of stroke. What's our key takeaway? After a TIA or stroke, check the LDL. If it's elevated, a high intensity statin is the evidence-based move. Let's bring it all together with a rapid fire recap. 1. Antiplatelet for atherosclerosis, anticoagulant for cardioembolism. 2. Global aphasia plus full hemiplegia plus eye deviation. Think MCA stem infarct. 3. Lenticulostriate arteries, MCA, not PCA. That is middle cerebral artery, not posterior cerebral artery. 4. After a TIA with a high LDL, SPARCL says start the statin. That's it for today's NeuroClarity session. If you enjoyed this episode, be sure to subscribe, share, and leave a 5-star review wherever you listen to this podcast. Got questions or cases you want featured? Drop them at the comment section. Until next time, stay curious, stay focused, and as always, keep your neurology clear with NeuroClarity. Bye for now.